Free to interrupt or ask any questions at any point. So at this lecture is going to review the basics of staging, um, and then become familiar with basic treatment paradigms for early stage locally advanced breast cancer and metastatic breast cancer. And I will focus more on the systemic therapy proportion. So again, some staging terminology. As we reviewed earlier this morning, we stage using the T&M criteria. And I think it's always a little bit tricky because there's the clinical stage, which is determined using the physical exam and imaging. And oftentimes this is the best guess as to what the true stage is. Because we know that our exam and imaging they're not perfect in terms of assessing the size and the number of lymph nodes that are involved. Or even the evidence of micrometastatic disease. So the pathologic staging is determined based on the surgical pathology. So after the surgery is done, we can really look at the size of the tumor, look at how many lymph nodes are involved. And generally this is more of, it's considered to be more accurate than the clinical staging. Although when we give treatment in the neoadjuvant setting, this obviously changes what we see at the time of surgery. Pathologic staging often determines the treatment after surgery and impacts prognosis. And many of the, because of the different types of stagings and the protocols that I'll be sharing today, I've focused on clustered staging, early stage, locally advanced, and metastatic as a simplified way to treat breast cancer. So we'll start with early stage breast cancer. And we reviewed the nuances this morning of sort of T&M based staging. But to simplify it, early stage is generally, resectable at the time of presentation when evaluated by a surgeon. And it's confined to the breast and ipsilateral axillary lymph nodes with a smaller size, tumor size in 5 centimeters with nodes that aren't fixed. And it's important that there's no chest wall or skin involvement. Breast cancers move towards locally advanced. Generally, they're not resectable at the time of presentation, or there's axillary lymph nodes that are fixed. But importantly, there shouldn't be evidence of distant metastatic disease or evidence of cervical or contralateral lymph nodes. So again, just to review, when we have patients who have early stage and locally advanced disease, the goal is to cure the patient. And in terms of local therapy, this is often surgery plus or minus radiation, if this is feasible, and then systemic therapy, the agents that we talked about earlier in the first lecture. And so we can sequence the therapy and the surgery and radiation, and that exact sequencing depends on the stage and the subtype. So sometimes we do the surgery first and then do adjuvant systemic therapy, and sometimes we do systemic therapy first and then surgery. And I'll kind of talk about how we decide when to do what. But one of the most important things, as we reviewed earlier, is that it's very important at the time of diagnosis for a patient who we think has a curative breast cancer, early stage or locally advanced breast cancer. It's important for them to meet with a surgeon and a medical oncologist, and a radiation oncologist if that's feasible, in a very timely manner to prevent the disease from progressing and therefore minimizing the chance of cure. So as soon as possible is always best. So when we think about doing neoadjuvant chemotherapy or neoadjuvant therapy, generally we reserve this for hormone receptor positive disease. We reserve this for locally advanced or unresectable disease at the time of presentation. Generally for hormone receptor positive early stage breast cancer, we go upfront surgery. So if the cancer is not resectable, then we administer neoadjuvant treatment, and then we assess for resectability, especially in ER and triple negative breast cancer. For HER2 positive breast cancer, we'll add in trastuzumab to the ACT regimen that we would give for ER positive or triple negative breast cancer. Certain subtypes of breast cancer, such as triple negative breast cancer, and in some contexts, HER2 positive breast cancers, we favor neoadjuvant chemotherapy. And the rationale for this is that we can tailor their outback therapy based on what we see at the time of surgery. And I'll talk about this in the case of triple negative breast cancer. Other considerations that we take into account are the general health of the patient. We really want to make sure that the patient can tolerate systemic therapy and that the patient can follow up in a timely fashion. And so if we're worried about patients' ability to come, due to whatever reasons they live far away or due to social situation, it's hard for them to come consistently to receive neoadjuvant treatment. This could influence our ability, our decision to go for upfront surgery if this is possible. So let's take an example of hormone receptor positive HER2 negative breast cancer. So this is probably the most common subtype of breast cancer that you'll see. One point to know is that the survival benefits of systemic therapy are the same, whether it's given before surgery or after surgery. So generally, like I said, if a patient has early stage disease and it's operable, we take them to upfront surgery. And generally, we do try to do that as soon as possible to prevent progression. If locally advanced and inoperable, we do neoadjuvant chemotherapy. And for ER positive breast cancer, almost all patients, except for those with the very lowest risk, will receive some form of chemotherapy, and all patients will receive endocrine therapy. So this is sort of the, for early stage, we'll do surgery. We generally wait 4 weeks or so to allow the patient to heal from surgery before starting adjuvant therapy, chemotherapy, and then endocrine therapy. And in locally advanced disease, we give neoadjuvant chemotherapy, wait 4 weeks, and then do surgery with either a mastectomy and axillary lymph node dissection or breast conservation surgery and radiation if that's feasible, and then start adjuvant hormonal therapy. So in terms of what every patient with hormone receptor positive HER2 negative breast cancer receives, like I said, most patients will get chemotherapy, and this is based on the resource stratified guidelines. Most patients will get ACT, which we talked about, every 3 weeks. It's reasonable to omit chemotherapy in patients with very low risk disease. So I tend to think about this in patients with much smaller tumors that also are node negative, and then older patients or frailer patients that we worry about their ability to tolerate chemotherapy. And generally with this regimen, it's about a duration of about 6 months. And patients have to come every 3 weeks at least to get their treatment. In terms of endocrine therapy, the agents that we talked about, aromatase inhibitors, tamoxifen, plus or minus a GnRH agonist, and this is given for 5 to 10 years. So let's maybe go over a case of a 40-year-old woman who presents with a 6-centimeter right breast mass with multiple palpable axillary lymph nodes consistent with locally advanced disease. Importantly, she doesn't have any skin changes or clinical evidence of metastatic disease. She has a biopsy of the breast mass and axillary lymph node, which show grade 2 invasive ductal carcinoma. It's ER positive, PR positive, HER2 negative. She has a staging chest X-ray and abdominal ultrasound and labs that don't show anything concerning for metastatic disease. So how do we approach this patient? I'll just give everyone a short amount of time to just make a note. So because she has locally advanced hormone receptor positive HER2 negative breast cancer, we would favor a neoadjuvant approach. So she, received neoadjuvant chemotherapy with ACT every 3 weeks. So how do we monitor her during treatment? In the neoadjuvant setting prior to each cycle, it's very important to measure and document the tumor size and lymph nodes. And I always pull out a measuring tape and really make sure that this is documented and in the chart so that we can make sure that the tumor is getting smaller. If we feel that the tumor is getting larger, it would be very important to then reconvene and have a multidisciplinary conversation and see if the surgeon can take her to upfront surgery because we don't, or change systemic therapies so that the patient doesn't progress and miss her chance of cure. So that's why that's very important. Again, it's also important to assess for the development of metastatic disease, just to ensure that the cancer isn't progressing, assess labs and toxicity of treatment, and again, because of the anthracycline use, have a baseline echo and monitor for signs and symptoms of heart failure. In the curative setting, it's very important to remain on schedule if possible, and prevent missing treatments or delays in treatments, as well as a higher threshold to dose reduce, because we really want to make sure, to the best of our ability, that we can cure this patient. And so we try to support the patient in every way we can so that they can come to their appointments, to have this opportunity for cure. And again, this is just for reference, a review of the schedule and toxicity of the ACT regimen that we talked about earlier. So this woman completed neoadjuvant chemotherapy. She tolerated treatment with very minor grade 1 neuropathy, just some tingling in her toes. So we didn't need to reduce her taxane. And she had a very nice response to treatment in the sense that it's smaller, about 4 centimeters. Though she does have multiple palpable axillary lymph nodes, though they're smaller than what was on presentation. She underwent a mastectomy and axillary lymph node dissection and was found to have 5 centimeters of residual disease with 5 positive lymph nodes. So what is the next step in management for her? So for ER-positive breast cancer, most patients after neoadjuvant chemotherapy will have some amount of residual disease, meaning that when we look at the time of surgery, the cancer, some amount of cancer will be there. It's very rare for patients with hormone receptor positive breast cancer to have a complete pathologic response, which can happen in patients with HER2 positive and triple negative breast cancer after neoadjuvant chemotherapy. So we're not totally surprised that she does have a residual disease, but she does have a fair amount of residual disease. She has, still a fair amount of tumor, and she has 5 positive lymph nodes. And so the next step for her, and in a setting where there's no radiation that's available, is to start endocrine therapy. So we talked about 3 different options in terms of how to reduce estrogen in the body. So how do we determine which medication to start? So we look at the patient's menopause status, premenopausal versus postmenopausal, look at the amount of disease that the patient had at the time of diagnosis, and also after surgery, to get us a sense of the risk of recurrence. Because she had a large tumor and multiple lymph nodes, she has a fairly high risk of recurrence. And then we sort of also take into consideration other comorbidities. She have a history of blood clot or family history of blood clot, which would sort of lean us away from using tamoxifen, or does she have osteoporosis, osteopenia, which plays into effect if she's going to be on a aromatase inhibitor. So generally for premenopausal women with low risk, so this is not our patient, we would do tamoxifen for 5 years. Patients with high risk, such as young age, large tumor size, multiple positive lymph nodes, if this is available, we opt for ovarian suppression with a GnRH agonist, or ultimately an oophorectomy plus endocrine therapy. And there's sort of 2 ways you can do it. You can start the Lupron, and then at the second shot, she should be suppressed, and then start the letrozole with the second shot. Or you can start tamoxifen, wait a few months, and then switch over to letrozole. But in these high-risk patients, they should be on endocrine therapy for a total of 10 years if possible. In postmenopausal women, so not in this particular case, but we know that aromatase inhibitors are more effective in postmenopausal women compared with tamoxifen. So patients should generally receive a minimum of 2 to 3 years of aromatase inhibitor. So there are a couple of different ways to do this depending on resources available. The most of, most people would do aromatase inhibitor, just start it and do that for a minimum of 5 years. If you're worried that a patient is going to have difficulty tolerating an aromatase inhibitor or it's not available, you could do tamoxifen and then switch over to an aromatase inhibitor for 2 to 3 years, or do an aromatase inhibitor for 2 to 3 years and then switch to tamoxifen for a total of 5 to 10 years. The important thing is that they get an aromatase inhibitor for at least a few years, since that's been shown to improve outcomes. And as I mentioned before, the chemo-induced amenorrhea is not considered menopause. So tamoxifen is really the treatment of choice in patients when the menopause status is unclear. So what about extended endocrine therapy? We know that for hormone receptor positive breast cancer, recurrence can extend, unfortunately, up to 20 years. And we also have data to show that extended endocrine therapy up to 7 to 10 years can prevent recurrence. Of course, we don't want to extend endocrine therapy in everyone because this can lead to unnecessary toxicity and cost. So the ideal candidates for extended endocrine therapy are really the highest risk patients. So these are premenopausal women with large tumors, multiple positive lymph nodes, high-grade disease, or postmenopausal women with, long life expectancy, at least 10 years or so, large tumors, node positivity, and grade 3 disease. How do we monitor patients on endocrine therapy for the duration of 5 years? And so this is sort of, can be modified depending on your context, but generally we use a combination of history, physical exam, and a comprehensive breast exam. And there's some variety, but during the first year, we generally see people every 3 to 6 months. In year 2, you can space this out. And again, this is personalized based on the stage of disease, the travel burden, etc. There really is no routine blood work or imaging unless clinically indicated. But for patients with higher risk disease, we generally have a low threshold to get imaging if they have signs or symptoms concerning for metastatic disease, although this is a clinical judgment. For patients with osteoporosis, patients on aromatase inhibitors, counseling regarding bone health, including, if possible, ensuring that they get adequate calcium, vitamin D, weight-bearing exercise. And then for tamoxifen, counseling regarding endometrial cancer, as well as venous thromboembolism. So, making sure that if they're having a major surgery, they hold the tamoxifen, or if they're going on if they're going for a long period without moving, like on a long bus ride or something like that, to also get around and move to prevent blood clot. So now we'll move on to triple negative breast cancer. So this accounts for about 10 to 15% of all breast cancers. And generally, neoadjuvant chemotherapy is preferred prior to surgery according to the resource stratified guidelines. So if the tumor size is greater than 5 millimeters, any lymph node involvement, a good performance status and young age, patients can get ACT. It's reasonable to omit chemotherapy in patients with very small, less than 5 millimeter node negative breast cancers, including microinvasive carcinoma. And it's reasonable to consider omitting it in patients with older age or poor performance status with these small tumors. So once a patient receives neoadjuvant chemotherapy, then they go to surgery. And if they have significant residual disease, meaning at the time of surgery, if they have a lot of cancer still in the tumor bed, then they would receive adjuvant capecitabine with 6 to 8 cycles. So this is again a 40-year-old woman who presents with a 6-centimeter right-sided breast mass with multiple palpable axillary lymph nodes, consistent with locally advanced disease. She has no skin changes or clinical evidence of metastatic disease. The breast biopsy and the axillary lymph node biopsy shows invasive ductal carcinoma, grade 3 ER negative, PR negative, HER2 negative. And she has a staging chest x-ray and ultrasound and labs that are negative for metastatic disease. Because she has locally advanced disease, she's treated with neoadjuvant ACT for 6 months, and she has excellent clinical response with 50% reduction in the breast mass, and the lymph nodes are no longer palpable. She undergoes a mastectomy with axillary lymph node dissection and has 2 centimeters of residual disease with no positive lymph nodes. What do we do next? So the management of triple-negative breast cancer with residual disease, we know that patients who have residual disease have worse prognosis than patients who have a complete pathologic response. And given the higher risk of recurrence with triple-negative breast cancer, and data from certain trials show that patients who have triple-negative breast cancer with residual disease after neoadjuvant chemotherapy have a benefit in terms of their outcomes if they're treated with 6 to 8 cycles of capecitabine. And this improves the likelihood, decreases the likelihood that the disease comes back, and also improves the patient's overall survival. And so again, this is 1250 milligrams twice daily of capecitabine for 14 days on of a 21-day cycle. And it's generally given for 6 to 8 cycles, in the adjuvant setting, so just 6 to 8 cycles. And I'd say that this is hard, it's a pretty hard to tolerate for patients. So most of, I don't think all patients make it to 8 cycles. So that's just something to know that it's fairly rough. Now moving on to HER2 positive breast cancer, that's either ER positive or ER negative. And I completely appreciate the comments that were made earlier in terms of HER2 testing not being available in certain contexts, such as Liberia. And so I'll try to go over this quickly. So for the standard of care for HER2 positive breast cancer, for all except for the smallest tumors, less than 1 centimeter, node negative, hormone receptor positive, or older age, generally we prefer a neoadjuvant approach with HER2-directed therapy. And so the approach really depends on the tumor size, nodal status. So if it's a small node negative tumor, we can get away with a more minimal treatment regimen with just Taxol and trastuzumab. If it's a larger tumor or node positive, then generally we add Herceptin to our chemotherapy backbone of ACT. Patients then will get surgery and then adjuvant trastuzumab for about 6 to 12 months. And generally, if it's hormone receptor positive, we start endocrine therapy after the chemotherapy portion is complete. And so this is just a reference in terms of the regimen, so and sort of the sequencing of events. So, in high-risk patients, they'll get this full, ACTH regimen with the taxane either being received weekly or and the Herceptin being administered every weekly or every 3 weeks. Both are reasonable. In patients who have lower risk disease, like less than 2 centimeters node negative, they will just get the TH in the neoadjuvant setting. Patients have surgery, and then again, we start the hormonal therapy while the patients continue on trastuzumab every 3 weeks for 6 to 12 months based on what's available. Now shifting gears to metastatic breast cancer. So metastatic or stage 4 or advanced breast cancer, like we had talked about earlier, this is cancer that has unfortunately spread beyond the breast and lymph nodes to other organs. Most commonly for breast cancer, this is the bone, the lung, the liver, the brain. Um, and I think the conversation, the point is well taken that the resources that we might use to stage cancer in certain situations, certain countries, such as CT, chest, abdomen, and pelvis, might not be available. But to the extent that we can, we should try to stage patients with chest X-ray or ultrasound if available, and labs, CBC, CMP, liver function tests at the time of diagnosis to really assess the degree of spread and to assess if the patient is in visceral crisis, which impacts the management. It's essential to obtain a biopsy at the time of diagnosis, and this not only confirms a diagnosis of breast cancer, because sometimes we can see liver lesions or lung lesions due to a whole variety of other conditions. So we really want to make sure that we're confirming the diagnosis of metastatic breast cancer. And it's important to also, again, characterize the subtype. So a patient who initially had a hormone receptor positive breast cancer or a HER2 positive breast cancer can recur and no longer express estrogen receptor or HER2 receptor. It's a little bit uncommon to go the opposite way, but this is important because this, of course, dramatically changes which pathway that the patient will go on in terms of treatment. So one thing to just differentiate is that the goals of treatment for metastatic breast cancer are different from the goals of treatment for early stage or locally advanced breast cancer. So for early or locally advanced breast cancer, we really try to cure the patient. But unfortunately, at this point, we don't have a cure for metastatic breast cancer. And so the goal is to really reduce symptoms from the cancer, help the patient feel better, and help the patient live longer to the extent that we can. And sometimes this is a very difficult conversation to have with patients, but usually at the time of diagnosis, we do like to, let them know that unfortunately that we can't cure their cancer. Although depending on the subtype of cancer, patients can live for, a fair amount of time, although it's challenging to predict how long. So when patients have metastatic breast cancer, they are on some form of treatment indefinitely, unless the treatment stops working or the burden of therapy outweighs the benefits. And typically how we monitor is we see the patients prior to each cycle of treatment. We examine them, we get labs, and then in certain settings, for instance, here in the US, we get imaging every 3 months, but this depends on the resources available. In the metastatic setting, stable disease is acceptable for tumor response. It doesn't always have to get smaller. It's always great if the cancer gets smaller, but if it's stable, that's good. If there's no growth, that's good. And that means we can continue treatment. And again, we would assess the ECOG regularly to make sure that the patient is not too frail or sick to receive treatment. Patients can live for months to years depending on the subtype of breast cancer, but this is always very difficult to predict. And these conversations are important to have as we assess how patients respond to treatment to ensure that they have understanding of the course of their disease. And attention is, we really want to pay attention to managing symptoms because we can't cure the cancer. We want to make sure that whatever we're doing helps patients feel better, support them from a psychosocial standpoint to the best of our ability, and then also do counseling on end of life, which I know we're going to talk more about in the next lecture. So I'll go through the 3 different types of metastatic, 3 different subtypes of breast cancer in the metastatic setting. So for hormone receptor positive breast cancer, we have 2 main buckets in terms of how we treat patients: endocrine-based therapies and chemotherapy. And the general principle is that we use the least toxic therapy to bring the disease under control.
Lisa, boleh aku jumpa guys?
Does someone have a question? I'm just gonna mute you. Rami, go ahead.
Feel free to interrupt if anyone has a question. So we use the least toxic therapy to bring the disease under control, and this is generally hormonal therapy, but we can use chemotherapy in patients when we need a very early and fast response, and this is what we call when patients are in visceral crisis. So if a patient has a high burden of disease in the lung or the liver, or a very severe wound, or liver with LFT abnormalities, we try to reach for chemotherapy because we want to have a fast response. It's faster response than endocrine therapy for most patients. And so generally what we'll do is we'll start chemotherapy, assess the response, either by labs or by imaging. And after the response is controlled, so let's say the patient had shortness of breath due to a lot of lung mets, and was hypoxic. After the response is, after the patient has a sufficient response, we always want to switch back to endocrine therapy, especially if the patient has never had endocrine therapy before, because this is often much easier to tolerate than chemotherapy. And like I said, generally we see the patient every 1 to 3 months. Well, generally, depending on the context, it's going to be 1 to 3 months. Get blood work before every cycle, and imaging and clinical exam as indicated every 3 or 4 months. So how do we treat de novo metastatic disease? So this is hormone receptor positive disease that presents metastatic at the time of diagnosis. So generally, principles are that in patients that have a good response to first-line hormonal therapy, it's reasonable to change to second-line hormonal therapy. But in patients who don't have a good response or no response or develop visceral crisis on hormonal therapy, we'd want to switch to chemotherapy. So for premenopausal women, you could do it either way. You could do tamoxifen until disease progression, then ovarian suppression plus aromatase inhibitor. Or you could kind of start with an aromatase inhibitor and do tamoxifen. There's no right answer. It depends on kind of your context and what's available. Of course, if there's no ovarian suppression that's available, it's not okay to start an aromatase inhibitor. For postmenopausal women, we can use aromatase inhibitor until progression and then tamoxifen, assuming that they had a decent response to first-line hormonal therapy. And if there's any indication that the patient is no longer endocrine sensitive, like they're progressing rapidly, then it's best to move on to chemotherapy options. So it depends on the context, but the chemotherapy options include capecitabine, taxane, doxorubicin, and fluorouracil plus leucovorin if capecitabine was not used. And these can be used for hormone receptor positive metastatic breast cancer after progression on endocrine therapy. It can also be used in triple negative breast cancer and HER2 positive metastatic breast cancer after first-line progression on TH. If a patient's received chemotherapy in the adjuvant setting, one question might be, well, can we reuse paclitaxel? And this really depends on the disease-free interval. So if a patient has recurred, very soon after they completed their ACT, like within 6 months, then generally we would not reutilize a taxane. But if it's been like 2 years, and it's okay to use the taxane again, because these agents are very effective for metastatic breast cancer. So back to our original patient who we talked about earlier, this 40-year-old woman who she presented with a locally advanced hormone receptor positive, HER2 negative breast cancer. She received neoadjuvant chemotherapy with ACT, followed by mastectomy and axillary lymph node dissection, and she had a fair amount of residual disease. I didn't put it here, but I think it was about 5 centimeters with 5 lymph nodes. She was started on Lupron and an aromatase inhibitor, and so put into menopause. And she's been receiving treatment consistently and presents 2 years later with a cough and shortness of breath. She's also hypoxic, and CT chest, abdomen, pelvis, or a chest X-ray could be done, depending on what's available, show lung nodules, pleural effusion, and bone mets. She undergoes a thoracentesis, which confirms that this is metastatic breast cancer, and she also gets a subtype which shows ER positive, HER2 negative, so same as her original cancer. What should the first line treatment be? So this is a clear example of visceral crisis while on endocrine-based treatment. So because she's in visceral crisis, we would start single agent chemotherapy. And generally, I think it would be reasonable to start with either taxane or capecitabine. One of the advantages of capecitabine is it's oral, it's well tolerated. You might get a quicker response with taxane. So either of these two options are reasonable. It would not be reasonable for her to go back to another endocrine-based therapy like tamoxifen, since given how rapidly she's progressed, we're concerned that she's no longer endocrine sensitive. So now I'll move to metastatic HER2 positive breast cancer, and I'll just do this very briefly. But we think about two different types of metastatic HER2 positive breast cancer. One is de novo, so when the patient presents with metastatic disease everywhere without having had a curative approach before, and the other is recurrent. So if a patient has de novo disease, then they would be started on first-line treatment, which would be Taxol plus trastuzumab. If they have recurrent disease, the question we always ask ourselves is, what is the treatment-free interval? And so if it's greater than 6 months, then we generally use the same approach as patients who have de novo disease. But if it's less than 6 months, we generally consider the patient not to benefit from a taxane plus trastuzumab, and then think about other agents such as capecitabine, palliative care. Doxorubin can also be used in this setting. So let's say in this situation, patient has de novo metastatic disease or a long disease-free interval after curative approach for an early stage HER2 positive breast cancer. They would start first-line treatment with paclitaxel and trastuzumab, and generally this is the duration of the chemotherapy is about 18 weeks of treatment, and we treat until best response, unacceptable toxicity, or disease progression. After about 18 weeks, we drop the chemotherapy and the patient is just on the trastuzumab every 3 weeks, indefinitely. If hormone receptor positive, patients can also add endocrine therapy after the chemotherapy is complete. And generally, patients do well with this regimen for a fair amount of time. Up to a year on the median, if they're able to get this treatment consistently. Although I know it's not available everywhere, and this gets to kind of the regimen we were talking about earlier. The paclitaxel can be given weekly with Herceptin, and that's at the dose of 80 milligrams per meter squared with a lower dose of trastuzumab, or the paclitaxel can be given every 3 weeks. With trastuzumab at a higher dose. So both of these are reasonable options. Alternative to a first-line regimen is capecitabine plus trastuzumab, and this can be used in patients who are intolerant to paclitaxel, but notably this shouldn't be used as second line after progression. And generally we do 6 cycles of capecitabine followed by maintenance trastuzumab. And then after disease progression on first-line trastuzumab containing regimen, we use the chemotherapy algorithm for ER-negative disease, omitting agents that have already been used. Same as ER-positive breast cancer, metastatic breast cancer patients are seen with labs prior to every cycle of chemotherapy, and then restaging assessment, either clinically or with imaging that's available, is done every 3 months. And I'll say that I know we talked about the toxicity of the TH regimen before, but I'll say that most patients have toxicity during the chemotherapy portion and can tolerate the trastuzumab fairly well. There is a small risk of cardiotoxicity, but we always obtain a baseline echo and then monitor either by echo, depending on availability, every 3 to 6 months, or by clinical status, ensuring that the patient doesn't have signs or symptoms of heart failure. So this is the last case. A 56-year-old woman has a locally advanced ER-negative, HER2-positive breast cancer. She was treated with neoadjuvant ACTH because she had locally advanced disease with tumor greater than 2 centimeters and node positive. And then she underwent surgery. She had a complete pathologic response. And 2 years later, she presented with abdominal pain, and CT chest, abdomen, pelvis showed metastatic disease in the liver, which was biopsied and showed recurrent HER2-positive breast cancer. So what is the first-line treatment for this patient, and what information do we want to know from the patient prior to initiating treatment? So given that the recurrence-free interval is greater than 6 months, we can re-challenge the patient with taxane and trastuzumab. And generally, we would give the taxane for about 4.5 months or until best response or toxicity, and then drop the trastuzumab and then drop the taxane and then give trastuzumab. Prior to initiating treatment, we want to know if she has any cardiac risk factors or history of heart failure, and if feasible, get a baseline echo. And we also want to know if she has side effects from the taxane, like did she have baseline neuropathy initially, as that might influence us to either start at a lower dose or do capecitabine plus trastuzumab. And then finally, social factors such as distance from the facility and the social situation, in which case we can consider the every 3-week paclitaxel. So, and then finally, I can share these slides, but these are the sort of the big picture, high level summary of the approach to different subtypes and stages of breast cancer based on their resource stratified guidelines. And I think that's it. So happy to hear people's thoughts or comments or questions.
Does anybody have any questions?
I actually have a question for the team in Liberia. I know that we had spoken about sending breast pathology from the JFK pathology lab to the path lab in Ghana, I believe, where the lead pathologist did some training. Does anybody know whether or not they're able to do HER2 testing? I know we talked about estrogen receptor testing, but I wasn't sure about HER2 testing. So I don't know if Dr. Gerard is still on, or if there's anybody from the oncology program at JFK who might know the answer to that.
I don't have any. I know they can do PR estrogen receptors and PR, but about HER2, I don't think they gave us information about that. If someone's from JFK, they can come in here. But I'll just find out from Dr. Kwate and see if they can do that also in Ghana.
Okay. Thank you.
Great. Does anybody have any other questions?
Thank you, Scott and Rami, for those very thorough presentations.
All right. So in that case, if there are no questions, we're going to call it. Oh, yep.
Yeah, thank you. Julius, once more. Thank you for the presentation. I'm just concerned about our setting, like Lauren was just saying. If a patient with a locally advanced CA, grade 2, went through operation, let's say mastectomy, but unfortunately, due to delay in supply or the patient availability, they could not start chemo within 90 days. So my question will be, your first focus was for curative intent, but now that you are taking that long period of time, if you have to initiate chemo, what would be your intent? Is it curative or you just thinking about palliative? And my next question will be a mother who is positive who is triple positive, but then she's a pre-menopausal mother. Your approach, are you still taking into consideration trastuzumab, or will you just continue with tamoxifen? But if you are just to continue with tamoxifen, what will be the outcome? What will you think if this mother is she RO positive? Thank you.
Yeah, those are really good questions. So the first patient, my understanding, and correct me if I'm wrong, is that this is a woman with locally advanced breast cancer who underwent mastectomy and axillary lymph node dissection, and wanting to give her ACT, but it's at least been over 3 months since she's had her definitive surgery. Is that right?
Right.
So I think that's a tricky question. I don't think there's a right answer. We know that when we give adjuvant chemotherapy within 90 days, that outcomes are better. So, but we also know that giving adjuvant systemic therapy in a situation like this would reduce the risk of recurrence by about 30%. And so I don't think there's a right answer. It would be kind of a conversation. I probably would not give her, I think I would discuss it with her, the risks and the benefits. And I might think, depending on the amount of residual disease that she had at the time of surgery, I might give her ACT, but I would probably not give her, indefinite treatment like it was a metastatic situation.
Thank you. So the second question I have to do with a pre-menopausal mother with ER2, PR2, and even the HER2 positive. Will your approach still be taking into consideration trastuzumab for the HER2, or will you just maintain the tamoxifen?
Yeah.
If yes, will you expect, what will be your outcome expectation for this patient?
Yeah, I think that's a tricky situation. So, I'm assuming that she's already had the baby and she's breastfeeding. Is that right?
Yes, you are right.
Yeah, I think that's tricky. We can't give the trastuzumab when patients are breastfeeding. It would be a discussion with her about her priorities in terms of breastfeeding, but certainly if she could, if she were to stop breastfeeding, then she could receive the trastuzumab. I don't think there's a right or wrong answer, but I wouldn't give it while she was breastfeeding or obviously pregnant.
Thank you.
With, Rami, with, Herceptin, isn't it like 7 or 8 months after they finish, like they can't breastfeed for a number of months, or is that, trying to get pregnant after?
Yeah, I mean, so definitely trying to get pregnant. I would assume that given the long half-life, it would also, she shouldn't breastfeed for 7 months after completing treatment. So I think it's really tricky. I think if she's okay with using formula and if that's available, then for a curative breast cancer in a young woman, I would probably favor stopping breastfeeding and treating with trastuzumab if that's available. But that's sort of a very personal decision, I think. That's a challenging situation.
All right, are there any other questions? Okay, in that case, we will call it a day. Thank you so much, Scott and Rami, for your presentation. We will meet back next week at the same time, and Allison Spearling will be giving talks on nursing considerations for cancer patients. So if anyone has any other questions, feel free to send me an email and I can send them along to the presenters. If you have any questions about the timing of the lectures, again, send me an email. But we should be all set. Thank you very much, everybody.